experience was just so horrific. But I'm sure people tend to forget over time, and counseling would be great outpatient.
I see that Dr. Patrick has her hand up.
Yeah. Good morning. Just a comment for me, kind of bouncing off of what Dr. Leiser said. I didn't see the email, but completely anecdotally, I've been here now about 7 years, and I don't think we had a single group A strep postpartum infection until this year, and we've had 2 so far in 2024. So I'm also curious if this is a thing. But anyway, thank you everyone for the nice presentation and for the comments from our subspecialist.
All right, are there any other questions? Can anyone tell me what was the role of the IVIG in her recovery? Why is that given?
As I understand, it's an adjunctive treatment for very severe toxic shock syndrome to deal with.
So this was recommended by ID. It was like the kind of a last ditch effort to see if it would cause improvement. There's really no good data on it, and it was supposed to be 3 doses. It also can cause thrombosis, so it doesn't come without any risk. So when we were kind of on the edge where like, oh, maybe she's getting a little bit better, but not better fast enough, or where we would have expected, ID recommended it. We decided to try it, and I did 2 doses, and I was like, I'm not going to repeat the 3rd because again, there is still risk of thrombosis. At that point, her platelets are already coming up, and I don't know if it would have made any difference if we did not give it to her.
I see that Dr. DeScenzo has her hand up.
Hey, yeah, I guess I don't know if we know the answer to this question, but if we, like going back to her vaginal swelling and the IND that didn't really result in anything, like, do we think that that actually helped with source control of the group A strep? Like, do we think that was the source? But it sounds like we really think it was endometritis. So I'm just kind of interested how the vaginal swelling part in the IND that we did fits into all of that. I don't know if anyone knows.
Yeah, I think the source was from the vagina because during the IND and the OR, they found this defect in the vagina that we're thinking is maybe the source of the infection. And that tracked all the way to her labia. I don't know if this was endometritis just because the patient did clinically improve after we did the OR IND.
I can add to that. I was on the next day, and I was made sure to be there for the first packing change with the resident, and the outer incision was not that impressive, but the inner incision, when we pulled the packing out, it was covered with pus. So I think that was it. I think it was a vulvar abscess. And I think that exploring it in the OR and washing it out was the source control that helped this patient. All right, well, with just 1 minute left, if there are no other questions, we'll just take a 60-second break, and then we'll switch gears and get ready for grand rounds. Thank you very much, Viraj. Great job, as always. All right, well, let's get started. Good morning, everyone. Thank you so much for joining us. In just a moment, I'm going to be asking Dr. Patrick to introduce our grand round speaker. But in the meantime, the usual announcements. We'll be taking attendance this morning using the participants list in the WebEx at around 8:10. If anyone's name is not displayed clearly, or if you're on the phone, or if two people are sharing the same computer, then you can text or email your attendance to me or Michelle or to Beth. And with that, Dr. Patrick, are you ready to introduce our speaker?
I am. Good morning. Okay, well, I am so pleased to introduce our speaker this morning, Dr. Suneet Chauhan. Dr. Chauhan is a physician with the Delaware Center for Maternal Fetal Medicine of Christiana Care. He's a board certified in both specialties of maternal fetal medicine and obstetrics and gynecology. Dr. Chauhan received his medical degree from the Sidney Kimmel Medical College at Thomas Jefferson University and has been in practice for more than 20 years. After completing his internship in psychiatry and residency in obstetrics and gynecology at Naval Medical Center Portsmouth, he went on to complete his fellowship in maternal fetal medicine at the University of Mississippi. Dr. Chauhan has come to us after years of experience working all over the world. Most recently, he spent the last 10 years at the University of Texas Health Science Center as the director of maternal fetal medicine. And honestly, as impressive as Dr. Chauhan's bio is, it really is so modest because when you look at his CV, it boasts nearly 500 research publications, numerous awards, grants in leadership positions. It reads like the MFM greatest hits, and he has been involved in work that has truly changed practice in that I quote back to my patients and my trainees basically every single day. I don't have the pleasure to know Dr. Chauhan personally, but our former MFM fellow, Dr. Fields, is now his colleague in Delaware. And when I spoke to her earlier this week, she said on top of being an amazing physician and researcher, he's also just the absolute nicest guy. So we are so pleased to have you here with us this morning at Rutgers, and I'm looking forward to learning a little bit more about some of the work that you've been doing, and I'm sure how you're going to change how we continue to practice moving forward. So I'll leave the floor to you.
Thank you, Dr. Patrick. Can everyone hear me?
Yes, loud and clear.
Thank you, sir. I can't see myself, so if I'm doing something unpleasant, please remind me. So this is an oxymoron title, a low-risk pregnancy and improving outcome. You can ask in the audience, well, if it's low risk, you can't improve outcome. And beside, what is an MFM doing talking about low risk? Because by definition, we should only take care of high-risk pregnancy. Let me begin with a simple outline. One of my mottos is define everything before you start a conversation. Give me the rate. Why should I care? And what can I do about it? Irrespective of what you're talking about. So that would be one of my pleas to the young people in the crowd. I always begin with ACOG because to me, that's where it all starts. And when you type in the search item, low risk pregnancy, you will get 68 hits. And I actually went through all of them. There's only one document which has anything of note, and that's OB Care Census number 9, levels of maternal care. Believe it or not, in there are only two sentences worth noting, that birth centers provide care for low-risk women. And the one number I want you to keep in mind, so you don't think I'm making it up, according to this census, 59, and I'm going to up it to 60% of all hospital births in United States happen in an institute where there are only 1,000 deliveries annually, so which is approximately 80 or 90 a month, let's say. So 60% of deliveries happen in a small hospital, and one could argue that that by very definition is low risk. Having said that, you have to leave your fingerprints on everything in life. So I asked around my colleagues, including Dr. Lewis, what is low-risk pregnancy? And this is the definition I got. A woman who does not have an appointment in high-risk clinic. Someone from Rutgers actually said Paris woman without any known complication. Someone said very pragmatically, good outcome for the maternal neonatal diet. I would like to submit, as of today, a low-risk pregnancy is if she is not supposed to get a third trimester ultrasound, period. You'll see this recurrent theme of this picture taken on January 17, 2018, time stamped by iPhone at 9:30 a.m., which is the time when I got to know the results of the ARRIVE trial. For those who know, the person in the foreground is Dwight Rouse, who has been pivotal in this journey. This is actual presentation of ARRIVE as a late-breaking session in 2018. And that's the screenshot of the New England Journal article. To put it in perspective about the nature or the magnitude of ARRIVE, you have to know Drazen was the editor of New England Journal. When he was retiring, he published an editorial. He called it the Drazen Dozens, articles that changed practice. To summarize his editorial, during almost 2 decades of him being the editor of New England, there were 80,000 manuscripts submitted, 4,000 were accepted, of which he labeled or he categorized only 12. 12 which changed the practice. This included colonoscopy and other things. There was only one GYN article in 20 years of New England publication which made the list, and one OB article which made the list. Let that sink into everyone's head. So to simplify and to take off on ARRIVE was a low-risk nulliparous women who were approached at 34 to 38 weeks, and they defined low risk, and admittedly in the appendix there's a great number of conditions which make it low risk, but it was that there was no contraindication for vaginal delivery, no prior C-section, which makes sense, and there was no medical or OB condition which required delivery before 41 weeks. For example, they said in the manuscript hypertension and fetal growth restriction, and I've highlighted things in color just for a reason. To me, ARRIVE can be summarized with a simple table and its number needed to treat. For the young ones, it is how many times you have to intervene, in this case, induction, to avert or to avoid one thing. So for example, in low-risk nulliparous, if you do 20 induction, you will prevent one nulliparous woman from having hypertensive disease. If you induce 28, you will avert one C-section in low-risk nulliparous. For respiratory support, it's 83. Please note the primary outcome, and we'll get into it later, is 93 with a very unyielding 95% confidence interval going to almost 17,000, suggesting the primary outcome is not significantly decreased with induction. Nonetheless, please keep these numbers if you want to jot them down as to what are the benefits of doing an ARRIVE induction. I'm going to start with this definition and work on it. A low-risk pregnancy henceforth should be considered a nulliparous who would qualify for ARRIVE, or I would say the one who currently in ACOG does not require a third trimester ultrasound if she happens to be Paris. Dwight and I began this conversation about low-risk pregnancy and complication, and his first question was, Suneet, we don't even know how many women are low risk. And if you think about it, there aren't too many articles or the definition. So one of the first thing we did was actually go define low risk in a more formal manner. APEX is an observational study which collected data from 25 centers across the country. They had over 110,000, of which 66% had a reliable term singleton delivery with a reliable due date, of which 55 were considered low risk by any definition. And this data is very granular and it allows you. So we came that at least in MFMU network at that time period, 55% of deliveries are low risk. You can say, well, those are part of national thing or network that doesn't apply across the country. We wrote, of course, in this, as you can imagine, the influence of Dr. Anand. We used on birth and death certificate data. We went out to define low risk as notable in birth certificate. And believe it or not, we came to low risk in 19 million to be about 60%. So 55% in Apex trial, 59% in birth and death certificate across the country, which also happens to be the number, approximate number of how many deliver at hospital with about 1,000 deliveries annually. To me, these days, I have to put it in perspective. What does it mean to be low risk? So in 2021, there were 3.6 million births. If you assume 60% is a reasonable approximation, there are 2.4 million births every year, which are low risk. And to put this in a simpler term, every minute of every day in United States, there are 4 children who are allegedly born of low risk using the simple definition. That's a number to keep in mind. Every minute of every day, there are 4 children of low risk pregnant women. This is my Sesame Street version, because to me, my motto is if you can't Sesame Street it, it's hard to comprehend. In low risk pregnancy, you identify the risk factor. Everyone is used to taking blood pressure, glucola test, and getting them weighed. And I would say that's overrated and overkill. But if you identify the risk factor, we have antenatal surveillance, and if need be, deliver induction depending on the risk factor at a given point to lower. And this is the underpinning of third trimester. If you could do a flow diagram in this graphic manner, please keep this in mind. I would submit to you in normal low risk pregnancy, there are 4 conditions. 4 conditions which increase the likelihood of adverse outcome. That includes small for gestational age, large for gestational age, and what I affectionately call OLI and POLY. So abnormality of amniotic fluid or fetal growth. There are 4 conditions. I would argue with you, they travel together, they have similar adverse outcome, and they have similar management schema, and you can bundle them as one complication of 4 component. All of them are associated with increased risk of mortality. They're increased risk of composite neonatal morbidity. All 4 have national guidelines. All 4 have known interventions and acknowledged and accepted timing for delivery. However, what's amazing is these 4 conditions, according to ACOG, if you're high risk, you get serial ultrasound like in hypertensive and diabetic, no one argues. But if you are low risk, to this date, ACOG recommends fundal height, and only if fundal height is abnormal, size less than date or greater than date, do you do ultrasound. This is so antiquated in my humble opinion, yet ACOG would still recommend fundal height measurement as compared to third trimester ultrasound. And ironically, this is the picture at MFMU network website if you ever go there. One of the characteristics when I was in Houston for 10 years was we used to call it Baja brunch. It was a Lebanese brunch. And if you know these people, among the 4, 2 of them have at least 1,500 publications. And when I started there and I was working on this project, and I would say at least 3 of them or 2 of them insisted that by definition, low risk does not have SGA or LGA. And if it does, it's really not associated with adverse outcome because by very definition, they're low risk. So SGA in hypertension, and I won't say which one of the 4 of us insisted that it's the SGA in hypertensive women which matters, not the SGA in low risk women without hypertension. So let's examine SGA in depth. SGA, as everyone knows, is birth weight less than 10th percentile. To put it in perspective, there are 32 million SGA in developing countries. and almost 250,000 SGA in low-risk pregnancy, to put it in perspective. These are acknowledged ACOG guidelines, acknowledgement of what goes wrong if you are below 10th percentile. Includes mortality, acidosis, neonatal seizure, intraventricular hemorrhage, even at term, and neonatal and infant mortality. Since no one believed us, so the very first thing we did years ago was actually take 9 MFMU network studies. And at that time, I think no one had combined the data from all 9. In Houston, we took these 9 publications. We had the data from the network, which was publicly available, and did the simple analysis. In 9 network trials, there were over 90,000 individuals. And if you exclude multiple diabetes, hypertension, deliveries, preterm anomalies, and potential duplicate, 59, once again, that number of 60% were low risk. And unlike what people said to me during Baha breakfast or brunch, 10% of them were SGA using Alexander curve. You can say, yeah, they're SGA, but they really are not associated with adverse outcome. Show me the adverse outcome. This is network while either in part of a trial or observational study like APEX. This is the rate of adverse outcome. Composite neonatal morbidity, as defined below, is 70% higher after adjustment in SGA compared to AGA. This is at term in low-risk women. Let that sink in, that the rate of stillbirth, neonatal death in network is significantly higher among SGA compared to AGA, period. So you can say, yeah, that's true, but we have an answer for SGA. All we have to do is identify SGA as being fetal growth restricted, i.e. ultrasound estimate fetal weight, or now AC less than 10th percentile. We initiate antenatal testing, whatever you believe in. We deliver them as indicated, and then we lower the morbidity. That assumes, the fundamental assumption is we identify all SGA before. Stated another way, every time a woman has preeclampsia, we identify them and we never miss a preeclamptic. This is a summary of detection of SGA. For us to call something suspected, and we were the first one in USA, this publication in 2010 from USA's our work in Wisconsin, of 1,500 women charts, consecutive deliveries, we looked at the delivery and we said anywhere in the prenatal or on admission on labor and delivery, did any clinician say the baby was growth restricted? And the answer was 10%. 90% of SGA were missed in Wisconsin. Our publication in 2013, Dr. Anand is a co-author, done at 4 centers because we didn't believe Wisconsin would represent it, is only 25. If you look at these 7 articles from 8 different countries, the likelihood that a SGA is identified as fetal growth restricted is 1/3. Imagine us missing 2/3 of diabetic. Imagine us missing 2/3 of preeclamptic or anything else we do so much in 3rd trimester for. There is one paper which has clearly shown, at least in Europe and Sweden, compared to detected versus undetected SGA. If you miss an SGA, there is increased likelihood of acidemia or seizure, cerebral damage, or death. And please look at the adjusted odds ratio, 4.1. So missing SGA is associated with adverse outcome, let there be no doubt. Or conversely, say we don't need to worry about SGA and don't measure the fundal height. Similarly, large for gestational age, defined as greater than 90th percentile. Believe it or not, by definition, there are 240,000 LGA in low-risk pregnancy. They are, without a doubt, acknowledged by ACOG to have adverse outcome. People forget LGA in low risk is associated with stillbirth, traumatic delivery, meconium aspiration syndrome, and mortality. This is a very simple way, but a nice graphic representation of what goes as the fetal growth accelerates from normal to LGA. From LGA, as everyone knows, macrosomia like fetal heart rate tracing is categorized 1. Then you increase the labor complication of chorioamnionitis or dystocia. When you go to category 2, as defined here, you increase the risk of stillbirth and neonatal mortality. Once you become macrosomic at 5,000 gram or more, you actually increase the likelihood of infant mortality compared to those who do not have macrosomia category 3. This is worth remembering that as the weight increases, so does the likelihood of and the severity of the complication. Same analysis, now we looked at the same 9 MFMU network trials and we flipped it to LGA. Guess what? 12% of low-risk women in the network have LGA. Their composite neonatal morbidity is also about 60% higher. So LGA is associated with adverse outcome. Undeniably, the stillbirth and neonatal death is not significantly different, in part due to small sample size, but at least no one should deny adverse outcome in LGA in low-risk women across the country in the network database is associated with 60% adverse outcome. Guess what? If you think we are bad at missing SGA and identifying them as fetal growth restriction, if you look at the delivery chart and go backwards, the Haywood article is ours from Portsmouth Naval Hospital. Only 10% of LGA at birth were identified having accelerated growth anytime in labor or during antepartum. Another article from the West Coast. The bottom line is we miss at least 90% of LGA and or macrosomic are not identified as being so before birth. We miss SGA, we miss LGA consistently across any study you have seen. Oligohydramnios is defined 2 ways. It is a known indication for antenatal surveillance. It is known, acknowledged reason for early, late term or early term deliveries. In a randomized trial we did, the likelihood in low risk women you would have oligo is 3%. Everyone has the definition of poly as acknowledged by ACOG and SMFM. It is associated with increased risk of stillbirth even in non-diabetic or low risk in Alabama. Its rate is about as high as 7%. So back to the 4 conditions. We have 4 conditions in low-risk women. They happen. We have a treatment plan, i.e. surveillance, indicated delivery, and improve outcome. But I would submit to you that ACOG does not recommend routine 3rd trimester ultrasound in low risk for multiple reasons. Some of them are that they think fundal height is sufficient. They think, and I've heard this, that ultrasound in low risk will increase the iatrogenic prematurity, i.e. at 36 weeks her AFI or her estimated fetal weight is 11 percentile. Let's induce her AFI is 5.1. Let's induce her, now you have more late preterm birth. There is some evidence and can therefore concern that knowledge of estimated fetal weight or AFI increases the rate of C-section without improving outcomes. And there's no evidence as of now, of this month, that doing routine ultrasound in 3rd trimester in low risk improves the outcome. So this is my summary. I know you're tired of this 4 graphic, but I would argue SGA, LGA they all, and oligo and poly, they are all associated with poor outcomes, including mortality. And I would submit to you that most of them are missed by fundal height or the current practice in United States. So observation is good, but my motto is observation is good, intervention is better. So this was our first randomized trial, and it's called UP trial, or for uncomplicated pregnancy. It had a lot of other subliminal message. Dr. Lade Shimi was one of my wonderful fellows in Houston. It was her thesis. It was a very simple, in low-risk women, the hypothesis was serial ultrasound. At this study, we did 2 ultrasounds starting at 30 weeks, 30 to improve or the detection. The purpose was to improve the detection of 4 abnormal conditions. In our main primary center, she screened almost 900 people. Majority were excluded for indication noted here. And this is in a referral center. 200 consented and 100 were randomized to get ultrasound every 4 weeks starting at 30 weeks. Routine care, which was if there's an indication, fundal height, decreased fetal movement, then clinician could get an ultrasound, but not indicated. This was a surprise. The composite of primary outcome, meaning detection of abnormal condition in routine care, is 8% compared to 27%. 1 out of 4 low-risk women would have one of these conditions at 3rd trimester. As there's number needed to treat, there's number needed to diagnose. So to diagnose these 4 abnormal condition or abnormality of growth or fluid, the number needed to diagnose is only 7. For every 7 low-risk women who underwent 3rd trimester ultrasound, you will find 1 abnormality. Undeniably, the composite maternal morbidity, defined here as in choreo, C-section, labor, infection, transfusion, and composite neonatal morbidity, these are in low-risk pregnancy, was not different. But please note the trend that those who got a serial ultrasound had a lower likelihood of composite maternal and neonatal adverse outcome. But it was not significant. Thus, if you do something once, you can always, or you should learn from it and improve it. So that was UP trial. We subsequently called it part 1. And then our fellow recently just finished this month, it's in the Pink Journal, UP trial part 2. One was a randomized trial, the other one is a pre and post intervention trial. One had 2 ultrasound at 32, 36 weeks. The second part, because our chairman was paying for this ultrasound, only had 1 ultrasound at 36. One had frequentist analysis, the other one has Bayesian analysis, and I'll keep it simple. In part 1, it was the detection. In this part 2, recently published, less than a month old, and I'm sure most of you have not read it. It was, does 3rd trimester ultrasound improve the actual outcome? So this is the PICO questions. In Houston, everything begins with PICO, and then I added S and an S with the $sign. So patient or population was individual who are low risk. Intervention was 1 ultrasound at 36 to 37 weeks compared to routine care, composite neonatal morbidity, and that was the plan. This is Dr. Roberts. He just became our faculty in Houston. And simple hypothesis: among uncomplicated pregnancy, ultrasound exam, indicated surveillance, indicated time of delivery, that 4-step Sesame Street flow diagram you have seen will improve neonatal outcome as compared to fundal height or indicated ultrasound. If you don't know the primary outcome from our ARRIVE trial, we mirrored to the best of our ability, except maybe for the APGAR, the ARRIVE neonatal morbidity. We wanted to show that a third trimester ultrasound done at 36 weeks will improve on neonatal morbidity and mortality. The difference between Bayesian is our thought process was considering the intervention is accepted, not known to be associated with adverse outcome, a 75% probability sufficed. We agreed on the sample size. We assumed in the pre-intervention or up trial part 1, the composite neonatal morbidity is 2.7. We needed 600 people in each arm, meaning pre and post intervention, only to be 75% sure. So please know here the Bayesian analysis starts with the assumption 75% reduction in adverse outcome is acceptable. Based on how many deliveries we were doing at 8 centers around the Houston, we needed 3 months in pre-intervention, and the intervention was done at 22 weeks anatomy scan, before 22 weeks anatomy scan. If you were low risk, we would follow up with an ultrasound at 36, 37 weeks. So you had 14 days to get the ultrasound, open label. The results in both arms are known, and the management was consistent with ACOG practice bulletin on the topic of growth restriction, accelerated growth, antenatal surveillance, and poly by SMFM. We were not inventing anything new except improving the diagnosis. This is a flow diagram. It's busy, but let me walk you through it. In the pre-intervention, so we were doing pre-intervention. No one knew about it. It had been IRB approved. 1,700 women, 57 got excluded because at anatomy scan, they had some high risk. Of the 744 eligible, low risk at anatomy, 568 were analyzed. The rest developed something like gestational diabetes, preterm labor before 36 weeks. In the post-intervention, we had 1,900 people who were screened at anatomy. They had a scheduled appointment at 36 weeks, and actually 600 underwent a additional ultrasound without indication because of what we call the up trial part 2. This is the maternal baseline characteristics, just to give you overview of the population in Houston. You can note there is a racial diversity in Houston. Caucasian was only less than 1/3 in both arm, but it's notable the race between the two peers changed, and we did adjust for it. About 40% were commercial, 60% were Medicaid. Please note the BMI did not go over 40 because anyone who had a BMI of more than 40 was considered high risk, and we did not include them per ACOG guideline. This is worth noting that the composite of antepartum complication, if you did third trimester, including hypertension, now you'll say that's odd. How can ultrasound decrease the rate of hypertension? I think it's similar to how does induction at 39 weeks decrease the rate of hypertensive disorder and ARRIVE? Surprisingly, and I don't have a good explanation, and I'm open to suggestion, the rate of cholestasis went up, and we have no good explanation. Here's another thing. Not only in the up trial part 1, which was a randomized trial with the frequentist analysis, in up trial 2, that a third trimester ultrasound detected one of the 4 abnormal conditions has a 100% probability. Number needed to diagnose is 7. Let me say this again. Up trial part 1, number needed to diagnose is 7 to detect one of the abnormality. Up trial 2, totally different design, multi-center across our system. The number needed to diagnose is 7. For every 7 ultrasound you do in 36 weeks, you'll find one of these abnormalities, and the 4 conditions, you can look at the number needed to diagnose. Everyone says ultrasound leads to induction and more because you find some abnormality, but guess what? Induction for fetal growth restriction, LGM macrosomia, polyhydramnios was minimal, with probability being 18%. The reason, if there was a reason for induction, it was because of fetal status, preventing gestational age approaching 41, or hypertension is what decreased. But here's the catch, which is an amazing result if you think about it. ARRIVE decreased the rate of C-section. If you induce them, if you can find the time and the place to do that in your labor and delivery, the probability you will decrease cesarean delivery is 98%. The number needed to treat to avert a C-section in a low-risk woman is 18. Let me repeat that. An ultrasound at 36 weeks downstream will decrease the rate of cesarean delivery. Number needed to treat is 18. You say, well, that's fine. That's hokey pokey. What about the composite? No one in the United States had shown that a third trimester ultrasound in low-risk women will decrease the composite neonatal morbidity. The probability is not 95%, which is what randomized trial require. Because the intervention is not harmful and easily accessible, for us, 75% was acceptable. Our results say 83% probability. Please note, need for ventilation for 24 hours at term in low-risk women is 81% probability. Neonatal death is 79 and 72. Number needed to treat to avert neonatal composite adverse outcome with 1/3 trimester ultrasound by a sonographer is 120. Not only did we decrease the composite neonatal morbidity, we decreased the rate of composite maternal morbidity. Please note the need for blood transfusion has a 99% probability because of probably decrease in C-section with 1/3 trimester ultrasound. The number needed to treat for maternal composite is 46. It does not have a 95 p-value of p less than 0.05, but we have a 90% probability that a single ultrasound will decrease the probability of composite maternal adverse outcome. Now, to put it in I call it the burden of disease. You can say that's an oxymoron also. How can you have a burden of disease in low risk? Back to simple calculation, 60% of all deliveries are uncomplicated. That's 2.1 million, let's say. Based on the up trial, 8% will be, if you do an ultrasound, all of them, 175 will be growth restricted, 175 would be LGA. Overall, 681,000, or let's say over 500,000, would have abnormality of growth or fluid. That is the impact across the country for doing a third trimester ultrasound. You will pick up, I'll even give you, I'll be pessimist and I'll say 500,000 more of the 4 complications. You can argue with me, as did during the Baja brunch, that low-risk women really don't have abnormality of growth and or oligo and poly. But if so, then let ACOG say that in low-risk women, oligohydramnios doesn't matter. And let me see you discharge a low-risk woman with AFI of 4 at 36 weeks. This is a comparison, and this is audacious. And I know a lot of you, the purists, will be mad at me for putting ARRIVE, juxtaposing ARRIVE and up trial, because there are multiple audacious. You can even say, Suneet, you're being bombastic and all that, and I would accept that. But this is worth remembering. In ARRIVE, the number needed to diagnose 4 abnormal condition, all SGA, LGA, oligopoly is unknown. Guess what? In up trial 2 and 1, it's 7. Cesarean delivery in ARRIVE trial, you have to induce 28 women to avert one C-section. In UP trial, it's 18. You can say, Suneet, the 95% confidence overlap, and I would accept that. I would also argue one is an induction, which we can't find time to do. The other one is an ultrasound, and I think we can find time to do an ultrasound. Composite neonatal morbidity in ARRIVE has unyielding 95% confidence interval of 17,000 as upper limit. Ours is 200. We can avert a major composite neonatal morbidity with an ultrasound with number needed to treat of approximately 125. We can avert a composite maternal morbidity with 50 ultrasound. Now, I will beg of you, no urine dipsticks, no blood pressure cuff, no gestational diabetes screening has this much ability. And if they do, they don't apply to so many people. This, to me, is the most influential thing we will ever do, because by doing third trimester ultrasound, we will improve the SGA diagnosis, LGA diagnosis. We significantly improve the diagnosis of oligo. We increase the diagnosis of poly. Everything on how to manage is known. We are not reinventing. We can improve the outcome by diagnosing not one, but 4 different process and just implementing ACOG guideline. So if you want to improve the outcome of 2.4 million births across the country, which is not just nulliparous, but Paris women too. So I would say we have upped ARRIVE trial. All you need to do is do an ultrasound exam at 36, 37 weeks. You arrive them at 39 weeks, if you can find the time or the place on your labor and delivery. And my simple thing for the young people in the crowd is yes, you can. And it took us 14 years to show this. I'm open for all questions and comments.
Dr. Chauhan, thank you so much for that excellent talk. Are there any questions?
I have a question. This is Dr. Patrick again.
Yes, ma'am.
Thank you so much again for your wonderful talk. So you have good timing, because I was actually just debating with one of my partners this week about if we could only do one ultrasound in the 3rd trimester, should we do it at 32 or 36 weeks? And I noticed, you know, between UP 1 and UP 2, when you had to pick one, you picked 36 to 37 weeks. So I'm curious if you did that based on UP 1, or if there were other factors that went into that decision, and if that's what you would recommend going forward.
Excellent question. It was both. So we actually dissected the UP1 randomized trial data, and we looked at how many people we identified at 32 weeks. And then we looked at the 36 weeks. Majority of abnormal conditions were detected at 36 weeks. At 36, 37-week ultrasound, and which makes sense to me. If things are getting worse or in terms of abnormality of growth or fluid, the more time you allow, the more likely you are to detect it. So if I had to do UP trial 1 again, I would just do 1. But if Bill Gates or MFMU network was funding this, then I would do it both.
I see that Dr. Sharma has her hand up.
Yes, thank you, Dr. Chauhan. This is Ruchira Sharma. I'm one of the MFMs here. Thank you for a very thought-provoking talk. My question is, do you have a deeper data on the interventions you did when, so if the polyhydramnios was diagnosed, was it mild, was it severe, and how many inductions were actually done in response to that? Say like we've identified AFI more than 30. Similarly, for growth restriction, what's the data on like how many severe growth restriction did we identify, say less than the third percentile, which would require even an earlier induction, like 37 weeks?
Excellent questions. We do have the data, and I think the Pink Journal article, and it's available now, has it. And if you send me an email, I'm happy to share with it. I would argue that to me, the question ought not to be which of the composite is found what often. To me, my focus is, can we improve the outcome? And dissecting it, is it because of A, B, C, D, is really not the focus. The focus is, can you do an intervention which is as simple as, I would argue, and I say it with respect, blood pressure measurement, and only in part because Baha was the one who was pushing me. How many blood pressure do you take to find one severe case? No one argues about taking the blood pressure. No one argues about, is gestational diabetes good control, bad control, and how much intervention we are doing, how many diet carbohydrate measurement we go through. Whether it's OLI, poly, I would just follow the ACOG guideline. 3% of your ultrasound should have estimated fetal weight less than 3% in low risk. To me, the comparison is not within this group. It is inconsistency of what we do to low risk women on the other side when they don't add up to 30%.
Thank you. I see that Dr. Schaefer has her hand up.
Hi, thank you so much for your talk. I wanted to know if you could just speak for a moment about the concern for over-medicalization of low-risk pregnancies. I know you stated in your talk that, observation is good, intervention is better, but we also know there's emerging research, like the Lancet study about too much too soon, that some over-medicalization of low-risk pregnancies can lead to disrespectful maternity care and ineffective use of healthcare resources, rising healthcare costs, as well as concerns regarding increased health inequities due to lack of access. And of course, also disruption of normal physiologic processes that are meant to be protective of maternal child health and potential for iatrogenic harm. So I wonder if you could just speak a little bit about that concern in this context.
And I appreciate that there are multiple questions in what appears to be a seemingly simple question on the surface. Let's start with overutilization. To me, overutilization has a connotation, it doesn't improve outcomes. Or if it improves outcome, it is really of not clinical significance. I would argue the counter. If you look at the composite, there is not one of them, if it happened to your family member, I call it make me cry. There is not a single component that you would not have a moment of, oh my God, why in my family member? So this is not about satisfaction, that they had greater satisfaction. This is not about pain control. This is about blood transfusion. This is about hypertensive disease. This is about C-section. This is about mechanical ventilation at term. And the number needed to treat is there for you to digest. And you can say, as a policymaker, this number needed to treat, let's say, of 10 is too much. And I would not institute that there's undue intervention for these outcomes when the number needed to diagnose and or treat is around 30. So to me, you as an individual, you as a policymaker in your department should make the thing, but look at the composite. And I would leave it at that. Regarding the access to care, I won't mention a name because I think this name has a bad connotation. There's a CEO who's noted that, let's just say, one of his product was not being used in an entire continent. And his answer was, let's give them satellites and they will use our content. You can argue whether we can do it or not, but I would argue you cannot talk about increased rate of C-section, increased rate of adverse neonatal adverse outcome in America compared to other developed country, and yet at the same time, when there is a simple ultrasound, we are not willing to do it. If we can do 1 hour post-glucola on every woman, if we can measure blood pressure in every woman at every third trimester visit, I would argue, why not do an ultrasound?
All right. Are there other questions? All right. Well, I guess that's it. Dr. Chauhan, thank you so much for this excellent talk.
Thank you all. Really appreciate it. Have a wonderful day and a nice weekend, please.
Yes, thank you. All right. So we'll end it here, and I wish everyone a safe and successful day. Thank you.